So, in our final section of this chapter, we're going to describe bone fractures, their healing, and treatments, followed by a summary of some other bone diseases and a little bit of information on osteoporosis. There are multiple ways of classifying bone fractures. A stress fracture is a break that's caused by abnormal trauma to the bone, sometimes from falls, sometimes from the impact of heavy athletics and military combat. A pathological fracture is where we see a break in the bone that's been weakened by some sort of other disease, like cancer or osteoporosis. It's usually caused by a stress that wouldn't normally break a bone in a healthy individual. Fractures are classified by structural characteristics, either the direction of the fracture line, whether it breaks the skin or not, and how many pieces the bone ends up being in. Here's a non-displaced fracture. We can just see a fracture in the bottom of the femur bone, it looks like. A green stick fracture is just like that. When you break a green stick, it's sort of twisty. And comminuted is when the bone is broken into 3 or more pieces. This table gives a list of the different names that we can classify fractures with, and a little bit of a description of each. By no means do you need to memorize all of them, but it's an interesting table to look through. What we want to pay attention to is how these fractures heal. In the uncomplicated situation, they'll usually heal in about 8 to 12 weeks. First of all, we'll see hematoma formation. The hematoma is going to be converted to granulation tissue by invasion of cells and blood capillaries. It is the bleeding of the broken bone that forms this clot, or the fracture hematoma. The blood capillaries, fibroblasts, macrophages, osteoclasts, and osteogenic cells are the types of cells that invade the clot. This granulation tissue is a soft fibrous mess that's produced by this capillary and cellular invasion, and it's usually complete at about 48 hours after the injury. Then we'll have soft callus formation here in 2. The soft callus is formed by fibroblasts and chondroplasts depositing collagen and fibrocartilage into the granulation tissue. Next, we'll see that soft callus convert to a hard callus. In the hard callus conversion, the osteoblasts are now producing a bony collar to surround the break. This hard callus is cemented to the dead bone around the injury site and acts as a temporary splint to join the broken ends together. This hard callus formation happens in about 4 to 6 weeks, and immobilization is necessary to allow it to form. After the hard callus is in place, we can work on bone remodeling. The hard callus will be there for about 3 to 4 months in all before the bone is remodeled. But osteoclasts are going to dissolve fragments of broken and dead bone, and osteoblasts will deposit more spongy bone to bridge the gap between the broken ends. This spongy bone will then be transformed gradually into compact bone that's slightly thicker than the fracture area. So in truth, breaking a bone and allowing it to heal makes it stronger in the region of the break. Now, there's a number of different ways that fractures can be treated. A closed reduction is where the bone fragments are manipulated back into their normal positions without surgery. However, an open reduction involves surgical exposure of the bone. Sometimes it involves use of plates, screws, or pins to realign the fragments and hold them in place. And the bones will go ahead and heal around these accessories. Most often, the bone is going to be immobilized to stabilize the pieces and allow healing of the bone. This is done in a cast. If the bone fragments are overridden by the force of strong thigh muscles, then we need to use traction to pull the bone fragments back into line. This happens a lot with femur fractures. The risk of this is long-term confinement to bed as the bone fixes itself. It's rarely used in the elderly because the stresses can be too much on the bone and cause other breaks. Hip fractures are usually pinned in the elderly. And early ambulation is encouraged. This promotes blood circulation, which of course promotes faster healing. Sometimes electrical stimulation is used to accelerate the repair. It works by suppressing the effect of parathyroid hormone in that particular region of the bone. The branch of medicine that deals with preventing and correcting injuries and disorders of bones, joints, and muscles is called orthopedics. It's a very vast field. So now let's take a quick visit to look at osteoporosis, because it's one of the most common bone diseases there is, and it results from a severe loss in bone density. The bone mass is lost and bones become brittle due to loss of both the organic matrix and the minerals. It affects the spongy bone the most because it's the most metabolically active bone. Patients with osteoporosis are subject to fractures of the hip, wrist, and vertebral column, and often have this pronounced widow's hump called kyphosis. This is a deformity in the spine that's due to weakened vertebral bones. Osteoporosis is most prevalent in postmenopausal white women. We begin to lose bone mass as early as 35 years of age. And by the age of 70, we've lost almost 30% of the bone mass. Big risk factors for osteoporosis, other than race, age, and gender, are smoking, diabetes mellitus, and diets that are poor in calcium, protein, and vitamins C and D. Estrogen has a big influence on maintaining bone density. That's why at menopause, women have higher incidence of osteoporosis. Without estrogen, the osteoclasts are going to resorb bone much more rapidly because estrogen functions to inhibit osteoclast resorption. In men, it's the testes and the adrenals that produce estrogen. In women, the ovaries. Women experience pretty rapid bone loss after menopause since the estrogen blood levels drop below about 30 nanograms per milliliter. Sometimes we'll see osteoporosis in young female athletes that have very low body fat. With low body fat, they stop ovulating. And when they're not ovulating, the ovarian estrogen secretion is very low. Without estrogen, we don't see the inhibition of osteoclasts, and so we see rapid bone loss. There are several different treatments that are common for osteoporosis, the first of which is estrogen replacement therapy. It's fairly controversial because although it does slow bone reabsorption by inhibiting osteoclast activity, estrogens also increase the risk of breast cancer, stroke, and heart disease. So you really have to balance out what the risks and benefits are. There are also a family of drugs that destroy osteoclast. Fasomax and Actonel are examples of those. Also, you could be injected with parathyroid hormone. If it's given as a daily injection, we've seen it increase the density of bones by 10% in just 1 year. That's a big increase. However, these parathyroid hormone derivatives can also promote bone cancer, so their use has been limited to about 2 years in each patient. The best treatment for osteoporosis, of course, is prevention. We can prevent osteoporosis by having regular exercise. Weight-bearing exercise is most beneficial. Not as in just running, weight-bearing your own weight, but weight-bearing as in weight training. When we put resistance on the bones, then as we've learned, the bones become more dense and it accentuates their mineral uptake. Also, a calcium intake of 1,000 milligrams per day is important for individuals between the age of 25 and 40. So be sure to stay up on calcium supplementation. This picture shows you some osteoporosis in vertebrae. The picture on the left here shows a regular matrix. Over on the right, you can see degeneration of this matrix. And on the far right picture here, you can see the degeneration of individual vertebrae as a result of osteoporosis. So that brings us to the end of our chapter on bone physiology. In the next chapter, we'll move into identifying bones and their features. For now, be sure to complete all the diagrams that we've talked about in this series of lectures. Do your Learn Smart modules and all the other assignments associated with this chapter.